Hello everyone, this is Dr. Shruti here. I work as a transplant pathologist in the BMT SRC of IMS BHU Varanasi. Right now it's very cold over here, but the point is we don't suffer much in this weather except that we wear a thicker sweater. But there are certain people or certain patients who have conditions which aggravate in this rapid change or severe change in the temperature, and sickle cell anemia patients are one such people. Now, before we go into the pathobiology of the sickle cell anemia per se, let's brush upon our basics first. So, we all know from our basic knowledge that hemoglobin are metalloproteins which contain iron, and their main function is to carry oxygen. And where are they present? They are present in the RBCs. Now, hemoglobin is made up of heme and globin, and this will be the structure of a hemoglobin. So each hemoglobin has got 4 globin chain, and each globin chain has got the heme molecule, which is the iron containing molecule, in the center, and each heme molecule can bind with one molecule of oxygen. One molecule of hemoglobin can bind with 4 molecules of oxygen. Now, what happens in sickle cell anemia? There is a single point mutation in the beta globin gene. Hemoglobin is made up of 4 globin chain, 2 alpha and 2 beta in adults. The alpha chains have 2 gene loci present in chromosome 16, and the beta chain has got 1 gene loci each encoded in chromosome 11. Now, if there is a single point mutation in the 6th codon of the beta globin gene, then from encoding glutamic acid, it will now start encoding valine. From our basic knowledge of biochemistry, we all know that glutamic acid is a polar amino acid and valine is a non-polar one. Now, why is this particular information important? This is important for us because we know that whenever your hemoglobin is oxygenized, it is in a relaxed form, and if it is unoxygenized, it is in a tense form. So every time an RBC is going through the lungs and taking up oxygen and then dissipating the same oxygen in the periphery, there is a structural change in the hemoglobin molecule. Now, what happens if there is a point mutation in the 6th codon? We can see that there is, because of lack of glutamic acid, this valine creates a sticky point. Now, whenever there is a structural or configurational change, valine will form a sticky end and they will start attaching itself with the nearby hemoglobin molecule, and thus forms a nucleus, and which proliferates further, forming a polymer-like structure. Now, this polymer-like structure, when proceeded, it will give rise to this classical sickle cell-like architecture. So from here we can understand that every time an RBC molecule is becoming deoxygenized, it forms a sickle-like structure, and when it is oxygenized again while traveling through the lungs, it again gets back its discoid shape. Now, this is how a sickle cell anemia looks like on a scanning electromicrograph. What we learned from here is that because of this continuous deoxygenation and oxygenation, there is a change in the structure of the RBC because of change in the configuration of the hemoglobin molecules. Now, this repeated change in the structure renders the membrane very vulnerable to damage, and after this repeated change, a point appears where the sickle cell becomes irreversibly sickled. That means they cannot go back to this discoid form even if they get the oxygenized hemoglobin. Now, what happens? This sickle cell, if they are numerous in number, they can cause microvascular occlusion, thus cutting off the blood supply to the downstream areas, or they can cause hemolysis. So this is the basic pathophysiology of a sickle cell disease. Now, where do we find sickle cell anemia patients in India? It's mostly seen in the tribal population. Now, if we see over here, the cases are mostly along the Eastern Ghats and the Western Ghats, and a few patients will be there in the central part of the India. It's quite rare in northern India. Now, how do we diagnose such patients. For any hemoglobinopathy, we have to have a basic CBC. So a hemoglobin assay has to be done, and then RBC indices like MCV, MCH, MCHC, red cell count, and RDW is mandatory. Now there is a basic difference between the MCV and of sickle cell patients and that of what we see in beta thalassemia patients. We all know that beta thalassemia trait is a close differential diagnosis for IDA, that is iron deficiency anemia. So these patients have a lower MCV, that is less than 75 femtoliter. Now, patients with sickle cell disease, even though the structure of the RBC is changed, mostly the MCV will be in the normal range, or it can be slightly macrocytic according to your report. That means the MCV can be more than 100 when there is increased hemolysis leading to increased production of reticulocytes. We all know reticulocytes have a bigger structure than a normal RBC. Like any other hemolytic anemia, red cell count in these patients will be high and RDW will be increased because of increase in variation of the structure of the RBC. Blood film and retic count is mandatory for all cases. What we see in peripheral blood, we will see sickle cell and retic count will be increased. Naturally, it is a hemoglobinopathy, so there will be increased production of the RBCs. Hemoglobin electrophoresis is a basic screening test, and definitive diagnostic test is a DNA analysis. Do a test and prove the mutation that we have just discussed. Now, what do we see mostly in peripheral blood? We see this sickle cells. These are the sickle cells. These are the reversible one, and these are the irreversible forms. And then these are the nucleated RBCs, and then this black arrow points towards the Howell-Jolly body. We know that uh, in sickle cell anemia, because of this microvascular occlusion, there can be autosplenectomy in homogeneous patients like sickle cell disease patients, not in the sickle cell trait. And this thing can, because of autosplenectomy, this Howell-Jolly body can be seen in the peripheral blood because pitting happens. Pitting means removal of this Howell-Jolly bodies from the RBCs after their production from the bone marrow happens with the spleen. Now, if the spleen is non-functional, naturally you will see these structures in the peripheral smear. Now this is a sickling test. This is quite easy and very routine test which we can use or employ to screen a patient of sickle cell disease. Now there are certain patients, if it is a trait patient, we will not see sickle cells in the peripheral blood. But and sometimes if it is a sickle cell disease patient and there is no condition which is precipitating, patient is not having a acute condition and there is not enough sickle cells, but you see few cells and you are suspicious about it, then you can do a sickling test. What we do in sickling test is that we take 1 drop of blood and we will incubate it with 2% sodium metabisulfite. Now what happens after incubation? There is increased deoxygenization of this hemoglobin leading to sickling formation. So this is what is the sickle cell test or sickling. It's best interpreted after 24 hours because we can pick up the trait patients also. Now sickle cells can have various morphology, and this is just a example or a picture from Winthrop's atlas where you can see it varies from the classical sickle form to boat shape to envelope form and oat cell form. So it can be various shapes and you have to be aware of them to pick them up from the peripheral smear. Solubility test is same as that of sickling test. It uses the same principle, just that instead of doing it on a slide, we are doing it on a tube. So if we incubate the sample in 2% sodium metabisulfite or so 2% sodium diisocyanate, then what happens in sickle cell patients? There will be increased turbidity because of hemolysis. Now, false positive cases can be seen in multiple myeloma patients naturally because of increased immunoglobulin production present in the plasma, which will give rise to natural turbidity. But that turbidity will be still there even if you spin the sample, and thus we can easily separate out a sickle cell patient from a multiple myeloma patient. Now what are these? These are the graphs which we gave after running an HPLC. HPLC means high pressure or high performance liquid chromatography, which is used to separate out various forms of hemoglobin that is present in the human blood sample. Now, the graph on the left hand side shows that there is 24.6% hemoglobin in the S window and 3.9% in the A2 window and 62.9% in the A0 window. A0 is the normal adult hemoglobin, which is composed of alpha 2 beta 2. S is obviously the mutated one. So we can see it is 24.6%. So what will be the diagnosis in such case? We will diagnose it as a sickle cell trait. It's a misnomer, or it's a myth to think that a patient of sickle cell trait will have 50% HbS and 50% normal adult hemoglobin. It doesn't happen like that, because HbS has a lesser or poorer rate of transcription and translation. So it will always be less than 50%. Now on the right hand side we can see S window is 59.9%. Normal adult hemoglobin is 6.3, it's hardly there. HbF is raised, it is 27.9%, and A2 is 1.7. So A2 is considerably low and F is raised and S is high. So we can think it to be a sickle cell homozygous disease. Now, how do we do a definitive diagnosis? I already have mentioned you have to do a molecular analysis. We can do ARMS PCR, or we can do restriction fragment length polymorphism. Now, there are various crises that can happen in sickle cell disease. Now, what are these crises? It can be a plastic crisis because of parvovirus B19 infection. There can be splenic sequestration. There can be hemolysis crisis and megaloblastic crisis. But the thing that we are going to discuss today, the vaso-occlusive crisis. Now, what happens in vaso-occlusive crisis is that because of chronic hemolysis, there is inflammation and increased adhesion molecules, not only in the endothelium cells but also in the neutrophils and platelets. So what happens? There is pseudo inflammation like environment, and the neutrophils will adhere, get activated and adhere with the endothelium, which are also activated, and this will give rise to further precipitation of activation of cells. Now, what happens normally in circulation? The normal blood rheology is dictated by the hematocrit, the plasma viscosity, and the erythrocyte deformability. Now, what happens in sickle cell anemia? I have also already told you that because of this increased switch in the structure of the cells, RBC cells, there is increased fragility and membrane weakness leading to hemolysis, because of which there is increased amount of cell-free hemoglobin or hemoglobin present in the plasma, which will lead to increased consumption of NO or nitric oxide. Because of this consumption, there will be microvascular occlusion, and which will enhance the microvascular occlusion. Now, RBCs are increasingly sticky because of this chronic hemolysis. There will be increased expression of molecules. So what happens in sickle cell disease is that there is chronic hemolysis, there is reduced red cell deformity, which gives rise to increased plasma viscosity because of the free hemoglobin that is being produced. And also there is increased, all these things will lead to increased expression of the adhesion molecules, not only on the RBCs, also on the reticulocytes that are being produced from the bone marrow. So there is an upregulation of the selectins, both P and E selectins, P for platelet, E for endothelial cells. And vascular cell adhesion molecules, one that is VCAM1 will also increase, ICAM1 will increase, and there will be marked increase in major leukocyte chemoattractants like interleukin 8. So all this will lead to endothelial dysfunctions and sterile inflammation. This is same as what we have learned in our basic pathology classes in second year. So what happens is that because of this increased in adhesion molecules, these neutrophils have undergoing rolling, then adhesion, then diapedesis. Same adhesion molecules are also increased and expressed not only in this neutrophils, they are also expressed in the sickle cells also, and also increased in the platelets. So there is hemolysis, heme production, and endothelial activation. Monocyte activation, because of this extracellular heme, there is NO depletion and monocyte activation. Monocyte activation will further lead to increase in interferon alpha and interleukin 1 beta, which will again propagate your endothelial activation. So this is the same thing in diagrammatic form. So there is chronic vascular damage leading to inflammation and cell activation. Multicellular adhesion happens leading to vaso-occlusion. So what happens basically? There is inflammation and cell adhesion, which gives rise to multicellular adhesion composed of endothelial cells, WBCs, the sickled RBCs and platelets, and all these cells will give rise to a vaso-occlusion and occlusive crisis in the end organ that is hampered downstream, and then gives rise to the end organ damage. That is, hallmark of this thing is severe pain. Now, how can we treat these patients or we can target specific sites of the pathobiology to help in the disease. So, if we do a transplant, this is like treating the disease from its roots, I would say. So, what we do, if we can do a allogenic bone marrow transplant, and then if we can reduce this polymerizations. Now naturally, when I say that this valine causes a sticky end, if the nearby or the neighboring hemoglobin also has a sticky end, naturally the stickiness or the propensity to form a sickle cell will increase. So that's what happens in a sickle cell homozygous patient. But there are certain hemoglobin forms which propagates this sickling, like HBD Punjab or HBC, but there are certain hemoglobins which also prevents it. The most important one is fetal hemoglobin. So we can increase the content of the fetal hemoglobin in such patients by giving hydroxyurea. We can also target vaso-occlusion by giving anti-adhesives, and we can prevent inflammations by giving vaso-occlusion preventions. L-glutamine can also be given. So this is how we can treat these patients. Thanks for your patient listening. Thank you.